World Medicine Universitet. 2017. Acne Vulgaris. Epidemiology and Pathophysiology. Acne vulgaris is a common disorder of the pilosebaceous unit affecting millions of people worldwide. Although most frequently encountered in adolescence, acne may persist well into adulthood and lead to significant physical and psychological impairment in those affected. The severity of acne may vary significantly from the mildest comedonal forms, 1, to a severe and debilitating condition, 2. In addition to the face, the chest, back, and shoulders are also commonly affected, 3, 4. Numerous factors, both intrinsic and extrinsic, 5, may underlie the development and the progression of the disease. Epidemiology. Acne is the most common cutaneous disorder in the Western world. In the United States, its prevalence has been variably estimated at between 17 and 45 million people. This number is typically based on a landmark publication by Craning and Odland, which estimated the prevalence of acne in persons aged 12-24 years at 85%. Several studies have documented that a significant portion of acne sufferers are post-adolescent or adult. A recent study based on 1,013 surveys found the overall prevalence of acne in patients 20 years of age and older to be 73.3%. Among such patients, women are affected at higher rates than men in all age categories. Thus, more recent studies place the incidence of clinically important adult acne at 12% of women and 3% of men over 25 years of age. If milder, physiologic acne is taken into consideration, the prevalence increases to 54% of women and 40% of men. Adult acne may present as a continuation of the teenage disease process or may arise de novo. Acne is also encountered in the pre-adolescent population, including neonates and, less commonly, infants and preteens. The prevalence of acne in individuals with skin of color has, likewise, been investigated in several studies, 6, 7. Thus, Halder et al. Reported acne being present in 27.7% of the Black patients and 29.5% of the Caucasian patients. Additional studies of adult patients in the United Kingdom and Singapore have placed the prevalence of adult acne at 13.7% of the Black patients and 10.9% of the Indian and Asian patients. It has also been shown that the presence of significant inflammation, resulting in the clinical appearance of nodulocystic acne, is more common in Caucasian and Hispanic patients than in their Black counterparts. More recent evidence indicates that subclinical, microscopic inflammation may be more common in the latter group. It has also been suggested that certain non-westernized societies demonstrate significantly lower prevalence of acne. The cause of such disparity is unclear, and although nutritional factors have been suggested as the cause of lower acne rates, this inference has so far not been conclusively substantiated. The issue of nutrition and its influence, or lack thereof, on acne has long been a highly contested one. Proponents of the link between acne and nutrition frequently cite nutritional influence on serum hormone levels, such as insulin-like growth factor IGF-1 and IGF-binding protein 3, to demonstrate the purported effect on acne. Thus, foods with a low glycemic load, those that cause least elevation of blood glucose and have lowest carbohydrate content, as well as diets high in omega-3 essential fatty acids, have been advocated as beneficial for acne patients. Additionally, milk has been proposed as a potential culprit in acne causation, with arguments being raised as to the presence of various hormones in the consumed product. On the other hand, those refuting the link between acne and nutrition may cite two flawed studies from over 30 years ago. In reality, controlling diet in a study is difficult, especially when it involves teenagers. As it stands now, there are far too few large, well-designed, well-controlled prospective clinical studies to substantiate either point of view. This is in accordance with the current guidelines of care from the American Academy of Dermatology. Smoking and its influence on acne prevalence and severity has been investigated in several published clinical trials. Of these studies, 2 suggested a positive association between smoking and acne, 3 proposed a negative one, and 2 found no association. Thus, the evidence so far is inconclusive. However, taking into consideration other, more serious health risks associated with smoking, cessation should always be encouraged. Very importantly, acne may arise in a number of genetic and endocrinologic conditions, and the genetic component of acne vulgaris has been well documented. For example, patients with the XYY genotype and those with polycystic ovarian syndrome, hyperandrogenism, and elevated serum cortisol levels have a significantly increased risk of developing acne. 8. Additionally, there is a high level of concordance in acne severity between monozygotic twins, while adult acne has been demonstrated to occur with a much higher frequency in those with first-degree relatives suffering from the same condition. Clinical assessment of acne vulgaris. Acne vulgaris frequently presents with a combination of morphological features, including open and closed comedones, papules, pustules, and nodules. 9-11. The mildest form of acne is comedonal acne, characterized by the absence of inflammatory lesions. On the other side of the spectrum is acne conglobata, presenting with large, interconnecting, tender abscesses and irregular scars causing profound disfigurement. More acute and severe in presentation is acne fulminans, a multi-system syndrome of sudden onset, characterized by necrotizing acne abscesses associated with fever, lytic bone lesions, polyarthritis, and laboratory abnormalities. In order to assess the initial severity of acne and to follow patient progress in a clinical setting, as well as to be able to evaluate the efficacy of various therapeutic agents in clinical trials, an objective measurement technique is important. Numerous systems have been developed over the years, however, no clear winner has so far emerged. The first published attempt to measure the severity of disease in acne appeared in a dermatological textbook in 1956. This technique assigned grades to acne severity, ranging from 1 to 4, based on the overall type and number of lesions, the predominant lesion, and the extent of involvement. Several modified grading systems have since been introduced, some utilizing reference photographs or polarized light photography. Developing in parallel with acne grading techniques were the various systems emphasizing lesion counts. This method typically involves counting individual lesions in each morphological category and frequently subdivides the face into separate regions. Lesion counting was recently validated and appears to be more objective than acne grading. Still, multiple arguments between acne graders and lesion counters have arisen in the literature, and none of the current methods of acne assessment are entirely perfect. Some systems actually combine lesion counting with overall grading. In reality, 2 standardized, validated systems are likely necessary, one that can be easily and rapidly applied in a clinical setting without the need for intricate instrumentation, and a separate, more sensitive approach that can be utilized in clinical research. Pathophysiology of Acne Vulgaris. Over the last several years, our understanding of the pathogenesis of acne has increased dramatically. The new research findings will likely lead to new advances in acne therapy, as well as the elucidation of pathogenesis of other cutaneous conditions. The traditional view of the pathogenesis of acne is frequently termed the microcomedone theory. According to this theory, the initial step in the disease process is hyperkeratosis of the follicular lining in the proximal part of the upper portion of the follicle, the infrafundibulum. This is accompanied by the increased cohesiveness of the corneocytes within this lining and results in a bottleneck effect within the follicle. As the shed keratinocytes and sebum continue to accumulate, they undergo a transformation into whorled lamellar concretions, resulting in a clinical appearance of a cum dun. Propionibacterium acnes bacteria proliferate within an expanding cum dun, prompt a host response, and contribute to the production of inflammatory acne, clinically manifesting as papules and pustules. Finally, as the shed keratinocytes and sebum continue to accumulate, internal pressure leads to the rupture of the comedo wall with subsequent marked inflammation and nodule formation. Such intense inflammation may eventually lead to scarring. 12. Although the basic tenets of the theory still appear to be valid, new research findings shed more light on the specific pathogenetic mechanisms underlying the various stages of the disease process and the progression from one stage to another. Additionally, the order of these events has been challenged by the new findings, suggesting a more complicated interplay of the various factors contributing to the condition. Some of these newer findings will now be examined. Follicular hyperkeratinization and corneocyte cohesiveness. Although considered key to the process of cum dun formation, the process of follicular hyperkeratinization is incompletely understood. Using staining for Ki67 antigen, it has been demonstrated that cellular proliferation within comedones, as well as within normal follicles in acne-affected sites, is higher than that in normal follicles in unaffected skin. It has also been shown that the addition of interleukin, IL-1 alpha to the infrafundibular segment causes hypercornification. Alternatively, it has been suggested that locally reduced sebum levels of linoleic acid, an essential fatty acid, may induce hyperkeratosis in the affected follicles. An analysis of the desmosomal components, however, failed to demonstrate a difference between acne follicles and normal controls, suggesting that the increased cohesiveness of the corneocytes within comedones is not due to alterations in these linking proteins. Recently, it has been suggested that the increased adhesion of corneocytes within comedones is actually due to a glue-like biofilm produced by the P. acnes bacteria. A biofilm is an aggregate of microorganisms enveloped in an extracellular polysaccharide lining. Although the formation of the P. acnes biofilm has been shown, its actual role in the increased adhesiveness of the follicular corneocytes has yet to be demonstrated. This finding may, however, challenge the traditionally established order of events in the pathophysiology of acne. Sebum production and hormonal influences. Androgens have long been implicated in the pathogenesis of acne. Androgens appear to play an essential role in regulating sebum production. Thus, acne development and sebaceous gland activity in prepubertal boys and girls correlate with elevated serum levels of dehydroepiandrosterone sulfate. This hormone is mainly produced in the adrenal glands, and its elevation in prepubertal children heralds the onset of adrenarche. As well, androgen-insensitive individuals do not produce sebum and are not affected by acne. Finally, a correlation between severe acne and elevated serum androgens has been demonstrated. Androgens are generated from the cholesterol molecule, 13. The reader is encouraged to review this steroidogenic pathway, which was recently summarized in detail by Chen et al. It has now also been shown that, in addition to the gonads and the adrenal glands, this process takes place in the epidermis and in sebaceous glands. However, the relative contribution of each of these sources is unknown. Once synthesized, testosterone is converted to dihydrotestosterone, DHT, through the action of 5-alpha reductase. Type 1 isozyme has been shown to be most active in the sebaceous glands, whereas type 2 is most prominent in the prostate gland. It has been shown that the activity of 5-alpha reductase is greater in acne-prone locations, such as the face, compared to non-acne-prone skin. Testosterone and DHT are the major androgens that interact with the androgen receptors in sebaceous glands, although DHT is 5–10 times more potent in this interaction. Once bound, the androgen receptor complex appears to regulate the expression of genes responsible for cellular growth and sebum production within sebocytes. However, the exact mechanism of this interaction has not yet been completely elucidated. The role of estrogens in acne is uncertain. Although it has been shown that very large doses of exogenous estrogen are able to suppress sebum production, it is unclear what function the physiologic levels of estrogens play in the regulation of the sebaceous glands. Estradiol and the less potent estrone can be derived from testosterone through the actions of aromatase and 17-beta-hydroxysteroid dehydrogenase. Both of these enzymes are present in the skin, as well as other peripheral tissues. The exact role of these hormones in acne will have to be established in future studies. Insulin-like growth factor 1, IGF-1, a hormone closely related to the human growth hormone, has recently been investigated as a possible contributing factor to the development of acne. IGF-1 levels have been found to be significantly elevated in post-adolescent women with acne and to be correlated with the number of clinical acne lesions in women, but not in men. Although these studies suggest that IGF-1 may directly contribute to the etiology of acne, the complex nature of interdependence of various hormones in the skin is not completely understood and deserves further studying. Additionally, receptors for other hormones, including melanocortin-5, corticotrophin-releasing hormone, and others, have also been demonstrated in human sebaceous glands. Although their exact role in the onset and propagation of acne is currently unknown, it has been suggested that these neuroendocrine mediators may underlie the effect of stress on acne. Role of Propionibacterium acnes and the host immune system. P. acnes is a weakly gram-positive, non-motile, rod-shaped coriniform or diphtheroid anaerobic bacterium long implicated in the pathogenesis of acne. In fact, several studies have demonstrated a higher number of P. acnes bacteria on the skin of children and teenagers with acne compared to age-matched controls without acne. P. acnes is known to produce porphyrins, particularly coproporphyrin 3, which fluoresces under Wood's light. P. acnes also synthesizes phosphatidylinositol, akin to eukaryotes, and has a distinctive structure of peptidoglycans in the cell wall. In addition, P. acnes produces various proteases, hyaluronidases, and lipases, which contribute to tissue injury. These properties appear to contribute to the complex interaction between the bacterium and the host immune system, the details of which are now emerging from the latest research. Several pro-inflammatory cytokines, including tumor necrosis factor, TNF, alpha, IL-1 beta, and IL-8, have previously been shown to be induced by P. acnes. IL-8 may be of particular importance in the host inflammatory response, as it is a major chemotactic factor for neutrophils. In addition, P. acnes has been shown to induce the expression of human beta-defensin 4, an antimicrobial peptide. More recently, cDNA microarray technology allowed simultaneous examination of multiple genes. Thus, a recent study by Trivedi et al. Demonstrated upregulation in a variety of additional genes involved in inflammation and apoptosis, such as granzyme B, responsible for cell lysis and cell-mediated immune response. Moreover, an elevation in activator protein, AP1, a transcription factor involved in inflammation, was recently demonstrated in acne lesions by Kong et al. Among the various genes regulated by AP1 are several matrix metalloproteinases, MMPs, which are directly responsible for extracellular matrix degradation. Indeed, the levels of MMP1, MMP3, MMP8, and MMP9 have been shown to be significantly elevated in inflammatory acne. With the pioneering work by Kim et al. 2002, these research findings now appear to be linked. P. acnes has now been shown to activate toll-like receptor, TLR2. TLRs are transmembrane receptors that mediate the immune response to molecular patterns conserved among microorganisms. TLRs are expressed on the cells of the innate immune system, including monocytes, macrophages, dendritic cells, and neutrophils. Some TLRs also appear to be constitutively or inducibly expressed on keratinocytes. In acne lesions, expression of TLR2, which recognizes peptidoglycans from gram-positive bacteria, has been demonstrated on macrophages in the perifollicular regions. When activated, TLR2 triggers a MyD88-dependent pathway that results in the nuclear translocation of NF-kapab, a transcription factor. NF-kapab then modulates the expression of various inflammatory cytokines and chemokines, most notably TNF-alpha and IL-1 beta, as well as several antimicrobial peptides. TNF-alpha and IL-1 beta may then act in an autocrine or paracrine manner to stimulate further immune response. Additionally, they can induce the activation of AP1, thus leading to the expression of MMPs, as described above. Of interest, the induction of IL-12 production by monocytes, which promotes the development of Th1-mediated immune responses, was also demonstrated to occur through the activation of TLR2 by P. acnes, thus linking the innate and the acquired immune systems. As the intricacies of the immune system and the host pathogen interaction are further elucidated, additional factors underlying the initiation and the propagation of the pathological processes in acne will likely be discovered. This will be crucial to the development of new strategies in the prevention and treatment of this common condition. And thanks for watching. World Medicine Universitet 2017